We start now. Question 1. 62-year female, suspected infective exacerbation of COPD. Chest X-ray shows no evidence of consolidation. Most likely organism is Haemophilus influenzae. Why it's the answer? What are the other organisms? This we will not understand unless we know the basic concept. Well, the three common organisms which lead to exacerbation of COPD are: number 1, Haemophilus influenzae, Strep pneumoniae, and Moraxella catarrhalis. These are the three most important organisms. Now, Haemophilus, Streptococcus, and Moraxella catarrhalis. Whenever the problem will be occurring with Streptococcus, patient will be usually having consolidation on chest X-ray. As in our case, chest X-ray shows no evidence of consolidation. So this is ruled out, right? So what I was telling you, if the patient had pneumonia, then we think about pneumonia means consolidation on chest X-ray, or maybe bronchial breathing on auscultation. They indicate that consolidation is there. But if there is nothing, then the streptococcus pneumonia is ruled out. And moreover, as I told you, chest X-ray was done, it is normal. Otherwise, Haemophilus influenza is the most common cause of infective exacerbation of COPD. Even the option of, suppose the question language was this, that which of the following is the most common organism which lead to exacerbation? Answer again remain the Haemophilus influenzae. So what the nice guidelines say that if you are getting pneumonia or pneumonic patch, then you think about streptococcal, otherwise your answer should be H. influenzae. So now in these patients, they should be treated with amoxicillin or maybe tetracycline. Maybe you can give a short course of prednisolone also. So now, as per NICE guidelines, how to manage case of acute exacerbation of COPD in detail. Well, it's one of the most common reason of people coming to the hospital, especially with the respiratory problem. Now, why and how patient will come to you? Dyspnea, cough, and wheeze. Cough is usually having sputum also. This one point differentiate from asthma. In asthma, of course, there is dyspnea is there, wheeze is there, but usually there is a dry cough is there, or a minimal amount of sputum. But in case of COPD, the amount of sputum is very high, very high. The reason being, because the cause of exacerbation is some infective pathology, like bacteria, which I mentioned to you, 3 important bacteria. In contrast, in asthma, it is the allergen which is causing exacerbation. That's why the cough is dry and there is not much of the sputum is there. Well, so, and moreover, increasing sputum suggests that is an infective etiology is there. But if the patient may be hypoxic, and that may come with acute confusion. So patient of a known case of COPD coming with confusion, that again indicate exacerbation. Point to be reminded to you, even confusion was even a bad sign in case of bronchial asthma also. So the 3 most common organisms are H. influenzae, Strep pneumonia, and Moraxella. And out of these 3 also, H. influenzae is the most common, as I told you in the previous slide, right? Well, in addition to that, respiratory viruses can also be the cause in around 30% cases. And after that, rhinovirus is the most important one. The point to be noted that it can be 30%. 70%, almost 70% are bacterial, 30% are viral, and rhinoviral is the most common organism. Now, nice guideline suggests how to manage this case of nice guidelines. Increase frequency of bronchodilator use and consider giving via nebulizer. So now the patient has come to you, you would like to give by nebulizer also. Give prednisolone 30 mg daily for 5 days. So he is adding oral steroid also. Okay. Something very interesting to talk. Something new, which is paradoxical by standard teaching. What he says, it is common practice for all patients with exacerbation of COPD to receive antibiotic. Yes, even you are treating in your emergencies when of COPD, you always give antibiotic. What nice guidelines say that a common practice for all patients with exacerbation to receive antibiotic. Even the NICE also says it's a common practice. But now what NICE says is do not support this approach. NICE doesn't support. They say don't give antibiotic. They recommend giving oral antibiotic only if sputum is purulent or there are signs of pneumonia. So what he says, you examine the sputum. If the sputum is purulent, that contain pus cells and bacteria, then only you give antibiotic, or you are getting evidence of clinical signs. Clinical signs, that means you are getting bronchial breathing or crackles. Then only you give antibiotic. Okay, but anyway, so we can give either amoxicillin or clarithromycin or doxycycline. We can give any of the antibiotic. So I hope you got something eye-opening thing, that even NICE guideline doesn't approach unless there are evidence of pneumonia or the pus is purulent. Well, which of the following is the most important in the pathophysiology of emphysema? Answer is destruction of alveolar wall secondary to proteosis is the answer. Let's learn more detail. Now, proteinases such as elastases. What they do? Now, these are the alveoli. Okay? Yeah. So, between the alveoli, we have these wall are there. So when we use elastases, what they do, they break down this part. Let me draw like this. So they break down this part. If this part is broken down, so this will become like this. This will become like this. Or again, day-to-day example I can give you. There is one room. There is one room. There is one office. There are certain partitions have been made, and different people are, and wooden partition are there. So definitely in this you get more area to sit. Now 4-5 people can sit in this room. Now somebody come and remove all the partition, it become like this. Now it become only one room. Same thing, the alveoli are like this, and when we use elastases, okay, elastases, they lead to removal of all these, and it become like this. So all alveoli, they become a single big and so-called emphysema. And smoking accelerate this process. It means smoking act like a fuel to the fire. Already fire is there, you are adding more fuel, the fire will become more. So that means smoking increases elastasis activity. So only one keyword is elastasis, and smoking. That's all, only one keyword. Now let us see what are the features which really exacerbate emphysema. Smoking, the reason I told you. Alpha-1 antitrypsin deficiency, when you just suspect this, suppose you are getting a emphysema patient in a young man of maybe 20 to 25 years who is a non-smoker, and you are getting feature of emphysema, you think about alpha-1 antitrypsin deficiency. Now I have a question for you. Write down the answer in your copy. Suppose you are suspecting one patient to be alpha-1 antitrypsin deficiency patient, and you are suspecting emphysema, and I want you to do investigation. What is the investigation of choice for this patient who has alpha-1 antitrypsin deficiency? Write down the answer in your copy. I give you 20 seconds to think and answer. Well, the answer is serum protein electrophoresis. This is the right answer. So, others which can lead to emphysema is cadmium, coal, cotton, cement and grains. And cadmium is used in smelting. Other are well known to you. But of course, smoking is the single most important which causes emphysema. Question 3. We are getting a case of COPD. Breathless despite using salbutamol inhaler. FEV1 is 60%. There is no history of asthma, eosinophilia and FEV1 variation. Next step. Next step is you use a combined long-acting beta agonist LABA with LAMA. LAMA is long-acting muscarinic antagonist, that is ipratropium. The golden line to remember, which is a summary of this question, is COPD is still breathless despite using SABA or despite using SAMA. Okay, he is using short-acting beta 2 agonist or short-acting muscarinic antagonist. Either of them he is using. Then, and there is no asthma and steroid responsive, as he is already clear to you. There is no asthma and no eosinophilia. There is no element of asthma is there. Then you add LABA and LAMA both, long-acting beta agonist and long-acting muscarinic agonist. So answer is E. Okay. So let's learn how to manage a case of COPD, stable management. But as per NICE guidelines, for the management of stable COPD, there is no emergency. Smoking should be stopped. Absolutely. Otherwise, the problem will never relieved. So, not only the patient is advised to stop smoking, he should also include offering nicotinic replacement therapy. That is varenicline and bupropion. These are the two drugs that we give to help the patient in stopping smoking. So friends, the two keywords are these two words you should know. They are the smoke de-addiction therapy we use like this. These patients should be given annual influenza vaccination. Why? Why annual? Because Haemophilus influenza is the most common organism which exacerbate the acute attack. But one-off pneumococcal vaccination. Now you should know what the meaning of one-off pneumococcal vaccination is there. Usually this we are giving every year, but this only single dose once only is good enough. That's why we use one of pneumococcal vaccination. So this is the general. We talked about smoking and vaccination. Now drug therapy. Start with SABA, or we can use SAMA. Any one we can use. Okay. Any one we can use. But if they are not, okay, if not, then the next step is, you have to really assess whether we are dealing with COPD or we are dealing with asthmatic feature suggesting steroid responsiveness. You have to be very sure that whether patient has asthma or steroid responsive. That's the thing you have to find out. Agreed? So the keyword are SABA or SAMA or. And after that, you have to find out whether we are doing asthma or steroid responsive. That is necessary to find out. Now, how do you know? Patient sitting in front of you, chronic smoker, age 60 years, but whether he has asthma element or not, the NICE guidelines has given certain criteria. You take the history. Patient says, yes, I had asthma or atopy, allergy history was there 30 years back. Then we are dealing with asthma-like feature. Agreed? First is the previous history. That means in the case of COPD, you have to take detailed history of when he started. Normally, COPD start 40-45 years age. We presume the patient starts smoking at the age of 15 to 20 years. And by the age of 40 years, patients start having COPD-like feature. But asthma patient may manifest at 20 years also. So one, the history. Number two, NICE blood eosinophil count. And one line very clearly written that NICE recommend a full blood count of all patients as a part of workup. So any patient who is coming to you with asthma or COPD, it's a mandatory that complete blood count should be done, and eosinophil count should be noted very carefully. Increased eosinophil count is a criteria which strongly suggests that you are dealing with asthma-like feature. Substantial variation of FEV1 over time at night or day. If the wide variation of FEV1 is there, that means we are dealing with asthma. Finally, again diurnal variation also of peak exploratory flow rate, same, okay, FEV1 or peak exploratory flow rate. If the variation is going on, you are dealing with asthma, okay. But again, something strange, NICE does not recommend reversible criteria. Very strange. Point to be noted when we talk about asthma. In asthma, the NICE guideline clearly says that history is supportive but not a diagnostic. You diagnose by FENO or by reversibility criteria on spirometry. But when he talk about COPD, then he doesn't go by reversible criteria, is not there. So now what NICE guidelines say, let me tell you that. The guidelines state that routine spirometry reversibility testing is not necessary as a part of diagnostic procedure, or plan to start initial therapy with bronchodilator or steroid. It may be unhelpful or misleading. This is what he says. So friends, beautiful question. If I were the examiner, I'll ask the question like this. All the following are suggested that it is asthma like, except I'll be giving you 1, 2, 3, 4. The fifth one will be reversibility criteria. Okay, so this is not a criteria as per NICE guidelines for COPD. Now, There is no asthma-like features, no asthma-like feature, and no steroid responsive. Okay, so we are dealing with pure COPD. Give LABA or LAMA. If only taking SAMA, discontinue and switch to SABA. Right? So in summary, what I told you that he's taking SAMA, switch over to SABA, or if not, then switch over to LABA plus LAMA if patient not responding. This is the summary of the whole treatment. Now, extra points. Asthmatic feature suggestive of steroid response. Who are the patient to whom you think they can respond to steroid? Okay, then in such cases, that means you got a patient whose eosinophil count is high, who has a diurnal variation or FEV1 changes. In such cases, give LABA and ICS, inhaled steroids. If they still remain breathless, then you go LAMA, LABA and ICS. That means you added LAMA to this. If taking SAMA, discontinue and switch over to SABA. Okay, and one more thing, NICE very clearly says as far as possible use a combined inhaler wherever possible. That means it is a mixture of two drugs that if there the NICE really recommends. So friends, this is a treatment of those who are steroid asthmatic or steroid responsive, and this was a treatment who are not steroid dependent and who are not asthmatic. Oral theophylline. Now they say theophylline should be used only when you have given a trial of short and long acting bronchodilator. They are not working. People who cannot use inhaled therapy, oh, it's very cumbersome, I cannot take, then you can go for theophylline therapy. So point to be noted, theophylline is not a routine drug that NICE guidelines advises. Traditionally, the theophylline, derifylline, the traditional trade name very often used in the clinical practice, they never recommend it. And whenever you are prescribing derifylline, if you want to prescribe antibiotic, especially macrolide or fluoroquinolone, okay, then dose should be reduced. Dose should be reduced of theophylline if you want to prescribe antibiotic, particularly macrolide or fluoroquinolones. Now, antibiotics, yes, to be given in some patients, in NICE guidelines indication I already told you, so no need to repeat. So what the drug that we prescribe? Azithromycin, the one which is more commonly recommended. Okay, it is especially for those who do not smoke. Okay, who do not smoker, and those who have standard therapy has been given, but still they continue to have exacerbation. But that means you are a patient who is taking proper treatment the way he was told, and he agreed and he stopped smoking also, but still he has exacerbated, then you prescribe azithromycin. Okay, so patient, so what else we can think if the patient not responding? Go for CT thorax. This is to exclude bronchiectasis. If the bronchiectasis has occurred, so definitely patient will keep on having problem forever. Sputum culture, this we do to exclude tuberculosis and to look for the atypical organism. The sputum microscopy and culture are done. LFT, liver function and ECG to exclude QT interval, because azithromycin or any macrolide can lead to prolonged QT interval. So that's why the reason why ECG should be done in these patients, and macrolide have a cholestatic picture, so that should be done. So they are the other thing that you like to do other than the antibiotics. Now, what are the factors which can improve survival in a patient of COPD? Smoking cessation is the single most important. Single most, you have to emphatically tell the patient, either you take cigarette or you take your life. Life or cigarette. What you want. You ask him to choose. And of course, almost everyone will like to choose first life. Then you say you stop this. Otherwise, you will lose the life. Long-term oxygen therapy in patients who fit criteria, and lung volume reduction is done in some selected cases, especially those who have emphysema or bulle. Those who have both emphysema and bulle are there. In such cases, we can think of going for lungs reduction surgery. 62-year-old woman, recently diagnosed COPD, FE1 65%, and she stopped smoking. She was given salbutamol inhaler, but still symptomatic and complained of shortness of breath. No history of asthma, no eosinophilia or FE1 variation. That means he's a case of COPD without any asthmatic element. The answer is, and remember, already taking salbutamol. So now you have to give LABA plus LAMA as we discussed in the previous slide. So COPD is still breathless using SABA or SAMA. Okay, now give LABA or LAMA. This as per NICE guideline I discussed in great detail in the previous question. So this is a summary that you got to remember. Question 5. Recently diagnosed with COPD. She occasionally breathless despite using SAMA, FEV1 45%, and she can stop smoking. Okay, but you have seen that being an asthmatic in the past, but only required salbutamol when she was exercising. Her prescription is salbutamol for the last 10 years. What the next step in management when she is okay, still breathless despite using SAMA. Okay. So friends, answer this question is C. COPD is still breathless despite using SABA or SAMA, and steroid responsive patient use LABA and ICS. This point I discussed in great detail in the previous questions. It's just to tell you how the question are going to be asked to you. So asthma, steroid responsive, LABA and ICS. Question number 6. A 54-year-old woman's chronic COPD, inhaled steroid. Main therapeutic benefit of inhaled steroid in patient with steroid. The answer is they reduce frequency of exacerbation. Why this is the answer? Reason for using inhaled steroid is reduce exacerbation is the golden line to remember. Golden line to remember is, remember, steroid we are preventing to use prevention of exacerbation. You are getting a patient with COPD, least relevant. Peak expiratory flow rate. Okay. Smoking history important, chest X-ray, full count, spirometry. D, again a shocking answer. But yes, this is the answer. Peak expiratory flow rate is no value in diagnosed COPD, but it is very, very important in bronchial asthma. Out of all the 5 options, it's the least important. So let us see how and what to do for diagnosis We have learned how to treat, let me see how to diagnose. We recommend to diagnose a COPD in a patient over 35 years. 35 years. Who are smoker or ex-smoker and who have symptom of exertional dyspnea, chronic cough or sputum production. The keyword are 35 years or above, smoker or ex-smoker, exertional dyspnea, chronic cough or sputum production. In such cases, you think about of COPD, then how to diagnose. Okay. So you go for FEV1 FVC ratio less than 70%. Less than 70%, you are doing spirometry. And you are getting this ratio as a less than, this means there is an obstructive airway disease. Obstructive airway disease. Chest X-ray, you may get hyperinflation, bulle, flat diaphragm. And they also exclude lung cancer. In fact, these three parameters, they indicate emphysema. Emphysema. Full count to rule out secondary hypoxemia. This will be done by showing by increased hemoglobin level. Increased HB level is there, then that indicates secondary polycythemia. Finally, body mass index calculations, again, because we know very well that chronic bronchitis, it occurs in obese patient. The BMI is done to look for that criteria also. Now, how to diagnose severity of COPD? Right? So, first of all, we go for FEV1 FVC ratio less than 0.7. That the one is a mandatory for to prove any obstructive airway disease. So that will confirm that we are dealing with COPD, obstructive. Now FEV1 more than 80%. This is stage 1. What we call as mild. 50 to 79% stage 2 moderate. 30 to 49 stage 3, less than 30 is severe, very severe. Okay. So these are the criteria by which we diagnose the severity of a case of COPD. Point ka FE1 FVC ratio should be less than 0.7. Then severity we talk more about FEV1 basing on how much mild, moderate, severe. Okay. Well, one more thing, little bit of measuring peak expiratory rate of limited value. It is not a very effective tool, peak expiratory rate. It may underestimate the degree of obstruction. Okay. Now, which of the following marker is the most useful for monitoring progression of patient with chronic obstructive airway disease? FEV1. Why? Why? Look, it is the FEV1. Suppose a patient has come to you with FEV1 less than 30% and you are treating, the patient become better. So it's the FEV1 which will be improving. This will not change. Why? Because COPD is a irreversible damage. It's irreversible in contrast to asthma which can be reversible. So that's why we want the patient should stop smoking so that further damage doesn't occur and whatever change you have to see, once it is 11.7, it's forever. Then after that, only FEV1 is there by which we can really see patient is better, worse, or what condition. So that's why FEV1 is the single most important criteria by which you can know whether the patient is improving or not. You are reviewing the COPD patient, and following factor prompt assessment of long-term oxygen therapy, hemoglobin of 18.4. Why? It indicates polycythemia. And this is occurring due to why? Due to chronic hypoxia. Chronic hypoxia. Okay. So he needs long-term oxygen therapy. So as per NICE guidelines, what are the indication of long-term oxygen therapy in a case of COPD? Okay. So NICE guidelines have clearly offered long-term oxygen therapy, what they write as LTOT. LTOT, long-term oxygen therapy. Okay. So these patients should, now again guidelines, how much? They should breathe supplementary oxygen for at least 15 hours a day. Oh, 15-hour day is almost 2/3 of the day. That means at least 8 hours of the night and at least 7 hours in the daytime also. So definitely in such cases you have to give oxygen concentrate to provide the oxygen therapy. Now who are the patient? Again, NICE guidelines. Of course they should be, because patient has come to you. Who are the patient who need this long-term oxygen therapy? If patient has severe airway obstruction, I told you when the FEV1 is less than 30%. I hope you remember the criteria of mild, moderate, severe and very severe. Okay. We can also, if it is between 30 to 49, that means in severe case also. This was very severe. We can consider in severe cases also. Cyanosis, patient having polycythemia the way in our question. Peripheral edema or raised JVP, they indicate cor pulmonale. Oxygen saturation less than 92% on the room temperature. All these are the indication of LOT. So FEV1 54% is not a criteria. Body mass index, this is normal. We want less than 92, and this should be FEV1, FEC. This is the feature of all. The feature of all obstructive airway disease. So this is not a criteria. So in this is the best answer. Question 11. We are getting COPD patient, FEV1 43%. Oxygen is O2 is 7.5. Most likely to increase survival is long-term oxygen therapy. So let's learn the detail. Stopping smoking cessation, the first thing which is going to help in the long-term survival. Second is long-term oxygen therapy. The second thing which is going to prolong his life. Okay. Long-term oxygen therapy should be offered to the patient with a O2 of less than 7.3 kPa, or those with a PO2 7.3 to 8 with one of the following. Let us see. In our case, it is 7.5. Okay. 7.5. That means patient is into this category. So let us see. Patient having secondary polycythemia, nocturnal hypoxia, pedal edema, or portal hypertension. If these are any one of them, then you should go for LTOT. Question number 12. We are getting a smoker, COPD, and now experience shortness of breath, cough with sputum, more frequent, most common causative organism. I think now the question is very easy. Deliberately I kept in the last. So he says most common organism of answer is H. influenzae. No discussion needed. I really want to have an easy question at the last. I want to have a very happy ending so that now you are well versed how to approach a case of COPD. Okay. Thank you very much. God bless all of you.